Hi everybody, good afternoon. You hear me? So my topic is gastroesophageal reflux disease and management of refractory heartburn. I have no conflict of interest. So as you all know, GERD, gastroesophageal reflux disease, is one of the most commonly encountered GI disease in the clinical practice. Significant compromise in quality of life, potential complications like stricture, dysphagia, gyrus, and leading to esophageal adenocarcinoma. So regarding American College of Gastroenterology guideline, GERD is defined as symptoms or complications resulting from the reflux of gastric contents into the esophagus or beyond. So it is into the oral cavity or even into the lungs. So regarding symptoms, the most common cardinal symptoms is heartburn and regurgitation. And other symptoms also included in GERD, water brush, dysphagia, chest pain, is non-cardiac chest pain, and other extraesophageal symptoms like cough, asthma, wheezing, and sleep disturbance as well. So this is the Montreal classification, classifying groups. It's esophageal syndromes and extraesophageal syndromes. Esophageal syndromes based on symptoms and endoscopic features like erosion or non-erosion, and the extraesophageal syndromes include other cough, asthma, or dental erosions, and other proposed associations like pharyngitis, sinusitis, and recurrent otitis media as well. So this is Los Angeles classifications of esophagitis, grade A, B, and C, and D. D is the most confluent erosions extending to the whole circumference of esophagus. And there are risk factors for GERD, and surprisingly, hereditary condition, relationship with family members contain more than 30% of cases. Overweight, obesity, central obesity, pregnancy, alcohol, and fatty diets, they all are risk factors for GERD. And pathophysiology of GERD is multifactorial: motor abnormalities, anatomical factors like hiatus hernia, obesity. In that impaired lower esophageal sphincter, LES rest syndrome, and the transient lower esophageal sphincter pressure relaxation is main pathological mechanism. Usually, transient TLESR is normal phenomenon for the healthy person, but in GERD, TLER is too prolonged, maybe too prolonged or maybe too frequent, which can cause stomach contact into the esophagus. Extraesophageal manifestations are conceptual proposed pathophysiologies are direct acid damage to the pharyngeal mucosa or bronchial microaspiration episodes can cause extra wheezing or other extraesophageal manifestation. So diagnosis is mainly based on the clinical symptoms, and empiric trial of acid suppression is often used as a diagnostic test. In the meta-analysis of 6 RCT suggests the high dosage of PPI, this is twice a day dose of PPI for 4 weeks, has acceptable sensitivity and specificity for diagnosis of GERD. So this is PPI trial is considered as an initial useful test for a primary care physician. We will do only further diagnostic tests only in case of refractory to therapy, complication, if you want to assess complications or to establish the alternative diagnosis rather than GERD. So these are the current available therapeutic modalities for GERD. Our lifestyle mainly is lifestyle modifications to raise head end of the bed from 30 to 45 degrees, avoid meals within 3 hours before bedtime, and weight loss. These strategies are definitely respond to GERD, one of the main therapy for GERD. And the other medical therapy like antacid, alginate, and proton pump inhibitors, H2 receptor antagonists, prokinetics, baclofen, and these are the medical management. And if it does not respond, or if there's indication for surgical therapy like fundoplications and endoscopic therapy, endoluminal therapies like strata, radiofrequency ablation of the GE junction. So these are the currently available therapeutic modalities. And the refractory GERD, I will also focus on the refractory case of GERD, because approximately 1/3 of patients continue to experience symptoms of GERD on once daily PPI, and 10% patient continue persistent symptoms on twice daily PPI therapy. So while on long-term PPI therapy, approximately 50 to 60% of patients complain persistence or breakthrough symptoms. So what is the definition of refractory GERD? It is defined as persistence of typical symptoms that do not respond to stable twice daily PPI dosing during at least 12 weeks of treatments. So this is up to 30% of the GERD patient experience refractory symptoms. So refractory symptoms can cause poor quality of health-related quality of life, and low work productivity, greater absenteeism from work, and psychological impairment, and significant health risks associated with long-term PPI is the additional complications of refractory GERD. There are many causes of PPI refractory GERD or heartburn. So they are related acid reflux related or other non-reflux related. So once patient is suspected of refractory GERD, you need to think about drug compliance or improper dosing of PPI, residual acid reflux, non-acidic weakly acid reflux, and the acid pockets, etc. And in addition to that, PPI metabolism, CYP2C90 polymorphism, and that Dr. Lai already explained this. And the other non-reflux related are functional chest pain, heartburn, and esophageal motility disorder, and eosinophilic esophagitis, though it is rare in the clinical setting. And then regarding drug compliance, if it is reflux related, you need to explore the drug compliance. Poor drug compliance and improper dosing. In case 38% of the patients only patient in GERD, only 38% of the patient strictly adherent to PPI, and 30% of the patients over 1 year, they only adhere only 30% of the patient PPI adherent. And the administration of the dosing and administration of the PPI also important. Administration of PPI should be 30 to 45 minutes before a meal is crucial, because gastric proton pumps are activated following food intake. And another theory is acid pocket. The acid pocket is an area of unbuffered acid compartment in the proximal part of the stomach, particularly in the fundus of the stomach, and it serves as a potential reservoir for acid reflux in healthy as well as GERD patients. So patients with GERD are predisposed to upward migration of proximal margin of the acid pocket. So the other mechanisms include weak acidic or non-acidic reflux. In that case, patient has no normal pH rates, but it's lower limit of the normal, but patient is hypersensitive to the acid reflux, and the PPI metabolism, CYP2C90 polymorphism. This genetic polymorphism, in case of rapid metabolizer, PPI efficacy is reduced. And nocturnal acid breakthrough, this is another theory. Persistence of intragastric pH less than 4 for more than 1 hour during the nighttime. That's why the H2 receptor antagonist, or adding of the H2 receptor agonist at nighttime is another therapeutic modality, but clinical significance is unclear in some studies. Eosinophilic esophagitis is, you also think about eosinophilic esophagitis in case of refractory GERD, because the symptoms of eosinophilic esophagitis is similar to the non-cardiac chest pain, like heartburn, chest pain, and dysphagia. And but actual prevalence of eosinophilic esophagitis is low. Another differential diagnosis, this is reflux unrelated cause, functional heartburn, because 60% of the patients classify as GERD, GERD has a functional heartburn, so that we have round diagnosis with GERD therapy, and they have less response to PPI therapy. So functional heartburn is defined in Rome 4 functional GI disorder criteria: burning, retrosternal discomfort or pain that is refractory to optimal anti-secretory therapy, this is PPI, in the absence of objective evidence of GERD or major esophageal motility disorder. So that these patients group has no GERD, no motility disorder. They only have a functional burning, retrosternal discomfort and pain only. So may have other they also have other coexistent functional disorders like functional dyspepsia and irritable bowel syndrome. And another cause is esophageal hypersensitivity. This is the presence of typical reflux symptoms, but in PH study, there is no acid reflux as well as in the no pathological reflux on endoscopy, but they have positive symptom reflux association. It means that patient doesn't have reflux, but patient experience the symptoms of reflux. So there's a positive symptom reflux association. It's different from the functional esophageal disorder. And esophageal hypersensitivity experience approximately 30 to 35% of patients with non-erosive reflux disease. So regarding functional GI disorder, this is Rome Foundation class of guideline started from 2000. In Rome 2 Foundation line show that heartburn and if patient is heartburn and normal endoscopy, we diagnose as one is divided into non-erosive reflux disease or functional heartburn, which include reflux hypersensitivity and non-reflux related heartburn. But in Rome 3, it moved to the Rome 3 in 2006, definitions a bit changed. Reflux hypersensitivity, abnormal acid exposure, and non-reflux related heartburn responsive to PPI. These groups included in the NERD, and another entity is functional heartburn. But the latest 2016 Rome 4 guidelines show that in patients with heartburn, normal endoscopy and normal pH, we divide it into functional heartburn and the reflux hypersensitivity. But if patient has a positive symptoms reflux association, we classify as reflux hypersensitivity. In case of patient without negative symptoms, reflux association, normal acid exposure, in these group are labeled as functional heartburn. And if the patient has positive or negative symptom reflux association, but in case of abnormal acid exposure, we include non-erosive reflux esophagitis. So diagnosis of refractory GERD again depend on the thorough clinical evaluation, and later on upper GI endoscopy, esophageal motility, manometry or reflux monitoring of this pH study. Clinical patient's history and physical examination is the most important for evaluation for reflux refractory GERD. We have to explore the patient's symptoms of typical or asymptomatic, the typical symptoms of GERD, or time of occurrence of troublesome symptoms. There is nocturnal or post-me or compliance, proper dosing and timing of PPI, presence of other functional GI disorders such as functional dyspepsia, insomnia, and alarming symptoms like weight loss, anorexia, or upper GI bleeding. And also need to explore coexistence psychological comorbidity. So if the patient with reflux symptoms, we have to, if the patient's PPI first step is to optimize PPI therapy. So improve compliance, ensure proper dosing time, split the PPI doses, or switch to another PPI, because there is a reason that we have a genetic polymorphism of CYP2C19 cases, rapid metabolizer. So we have to change another PPI which does not metabolize by CYP2C19. It is rabeprazole, for example. And lifestyle along with PPI dosing and the timing, lifestyle modifications also important. Avoid large spicy fatty meals, lose weight, head elevation, and avoid eating 3 hours before bedtime. So another studies, reflux monitoring. Patients who are refractory to PPI therapy, normal endoscopy should undergo reflux monitoring. It is whether the patient has acid reflux or not. So that reflux monitor acid exposure time, number of reflux episodes, and symptoms index and symptoms association probability. So in case of reflux monitoring, we can do PPI on therapy or PPI off therapy. In PPI off therapy, reflux monitoring is indicated in case of GERD, which is unproven and no prior positive pH testing. And in case of patient who undergo surgery or endoscopic reflux therapy preoperatively. And on PPI therapy, reflux monitoring is performed in patients with proven GERD in form of severe esophagitis and long segment pruritus and prior abnormal pH tests to establish relation between reflux episodes and symptoms. So another modality is high-resolution esophageal manometry. Although it is not the first-line test, HRM has a role in defining GERD alternative diagnosis, achalasia, rumination syndrome, and supragastric belching. And it's also useful for esophageal peristalsis function before definitive surgery, anti-reflux surgery, to predict post-operative complications like dysphagia. And HRM is also performed to localize the lower esophageal sphincter before placement of pH probe. So combine multi-tunnel intraluminal impedance pH monitoring is used in off or on therapy, and this is considered as a gold standard in the evaluation of PPI refractory GERD. So these are the medical management. We have to start with medical management in case of refractory GERD. For patient with abnormal endoscopy, pH testing or impedance testing, it is coexistent with reflux as the etiology of symptoms. So patients still have reflux GERD, confirmed GERD by endoscopy pH test, pH impedance test. We have to use PPI. It is the mainstay of therapy, and we have to make sure proper timing, compliance, and avoid CYP2C19 polymorph metabolizer. And long-acting, and then we can also use long-acting PPI with alternative metabolic pathway like elaprazole or tanajoprazole, which is not available in our country, and also potassium competitive acid blocker, PCAP, rivaroxaban or soraproxen, etc. Alginate acids work by forming a mechanical barrier between gastric contents and the lower esophageal sphincter. This is useful in case suspected of acid pocket. In multi-center placebo control randomized trial show that alginate is effective symptoms improvement when it's combined to PPI. It's compared to placebo. Prokinetic drugs, it increase lower esophageal sphincter pressure, enhance esophageal clearance of reflux material, stimulate gastric emptying time, so that it is theoretically it is useful drugs for refractory GERD. But in the meta-analysis, the addition of prokinetics to PPI has no significant effect on symptoms or endoscopic response to GERD, but its quality of life is better in meta-analysis. And other reflux inhibitors like baclofen, it inhibits transient LES relaxation. It is GABA agonist and decrease acidic and non-acidic reflux episodes. You can use as a monotherapy or add-on therapy to PPI. In the meta-analysis, baclofen reduced the number of reflux episodes, average length of and occurrence of TLE, transient lower esophageal sphincter relaxation. But this is because of the neurological side effects, most of the patients not tolerate to these drugs. And neuromodulator, it is very useful for the esophageal hypersensitivity and functional heartburn. This is alternative diagnosis for GERD. In randomized trial, citalopram is compared to citalopram and placebo group. Citalopram is only 38% of the patient with citalopram group reported reflux symptoms. And also fluoxetine reduces the percentage of heartburn-free days. What is the role of endoscopy in refractory GERD? Usually, ASGE guidelines recommend that usually endoscopy is not indicated in the patient with GERD. But in case of refractory GERD, we can diagnose erosive esophagitis or Barrett's esophagus and rule out eosinophilic esophagitis and suspect severe esophageal motility disorders or pill-induced esophagitis or esophageal lesions associated with skin disease like lichen planus. So this is an endoscopic management of GERD. If the patients fail response to medical therapy, we can try with endoluminal management of GERD. These are the radiofrequency ablation called Stratter procedure, endoscopic fundoplication, multiband anti-reflux mucoectomy. And the endoscopic fundoplications, the basic, all the endoscopic managements of basic principles are endoscopic plication and reinforcement of esophageal junction. But in systemic review and meta-analysis, and these endoscopic procedures are safe and effective in patients with refractory GERD, and adverse effect is overall adverse effect rate, event rate was only 2%, and PPI can discontinue in even 89% of the patients after therapy. But we don't know the long-term outcome. The surgical management, laparoscopic fundoplication or anti-reflux surgery, Nissen fundoplication is effective in patients with typical GERD symptoms with acidic or non-acidic reflux. And the long-term LAS provides greater reduction in esophageal acid exposure after 5 years compared to PPI therapy. So this is the management algorithm for GERD. If patients' GERD symptoms are like heartburn and acid reflux, we will start with PPI therapy with empiric single-dose PPI therapy or lifestyle modification. If the symptoms resolve, taper PPI therapy to lowest effective dose. If symptoms persistent, we have to ensure compliance, proper dosing of the PPI or twice daily PPI. Can improve twice daily PPI use for another 8 weeks. And if the patient is alarm symptoms, we have to do endoscopy or other further investigation. If patient refractory to GERD symptoms, we have to evaluate again PPI regime and compliance. If it is adequate, we have to undergo pH monitoring. If patient has persistent acid reflux, so this is NERD or we will proceed to newer long-acting PPI, alginate add-on, or anti-reflux therapy or endoscopic therapy. This is confirmed acid reflux disease. If patient is non-acidic reflux, we have to add prokinetics, baclofens, or anti-reflux therapy, endotherapy. Still useful. And patient is esophageal hypersensitive, no reflux, no acid. So we have to think about alternative diagnosis like functional esophageal disorder, so that this must be treated with neuromodulator like tricyclic antidepressants or SSRI. I'm sorry. Also, in conclusion, GERD is common disorder, definitive diagnosis and alternative diagnosis mandatory for refractory GERD. Various medical therapy, endoscopic and surgery are available, but indications, long-term outcome and safety need to be considered before prescribing these therapy. Thank you very much for your kind attention.